Right, so it's Rachel, I'm one of the registrars. I'm gonna talk about PDAs. I'm gonna do it in a slightly different way to how I've ever presented before. So I'll be interested to hear your thoughts on how it's gone. I'm gonna do it in this sort of whiteboard sort of effect. So this is everything we're gonna talk about. We're gonna zoom in and talk about different things, and there'll be a bit of drawing. I had to somehow fit drawing into my presentations because I was going mad. Okay, so PDA, let's get started. So what is a PDA? I mean, they're all senior people on this chat at the moment, but who cares? Let's go through it anyway. So you've got, this is my rubbish drawing of a heart. Blood comes in this way, into the right atrium, right ventricle, and up to the pulmonary arteries, heads off to the lungs, and then gets all oxygenated, comes into the LA, down to the LV, up to the aorta, supplies all the head and neck vessels, and heads off down to the body. The PDA is this thing here that we all know about. This connects the aorta, usually the underside of the aorta, to the left pulmonary artery, or the main pulmonary artery, LPA junction. And you just get mixing. So usually, as we'll talk about in a moment, you get left to right shunting, but you can be bidirectional. So that's what we're talking about. So I thought for funsies, we'd go to the fetal life just to wake you all up. And where it came from, because I found this really interesting. Naturally, I'm a nerd. But it was quite helpful to understand where it came from, because it actually makes a lot of sense with things like head and neck anatomy when you get vascular rings and stuff like that. So right, here we go. So the first few weeks of life, the embryo looks a little bit like this, and you've got blood that comes in from mum, and it supplies all your organs down here. But this is the bit I'm interested in here. So this is your aortic sac, just here, and your intersegmental arteries. Now, if you kind of cut it that way and look at it from that direction, you open it up and you get this. And the body's really smart. I mean, I find it fascinating. I never got bored of how the body makes such a perfect little human being. But to create... the body's created this. The final product has got to be something that looks like this. And it's really interesting how the body does it. So it's made all these intersegmental arteries, and it's happy with those, but it doesn't need all of them. So it just gets rid of some. So it degenerates, so it doesn't need these two up here. So it gets rid of those. It doesn't need these two up here, it gets rid of those. It doesn't need these two either. Gets rid of all those, doesn't need this bit, degenerates that, and on the other side it just gets rid of this one. So we're kind of starting to look something that might start to represent a head and neck sort of anatomy. What then happens is you've got down the bottom end, the artery and the main pulmonary artery and the aorta start to septate, and that's what didn't happen in that truncus that's been born. It starts to septate into an aorta and a main pulmonary artery. And as that's happening, up the top end, this is kind of degenerating and septating as well. And this creates your first branch here. So this is coming up here, and this is your first branch that's been made over here, and that's your brachiocephalic artery. Make this a bit smaller. That's your brachiocephalic artery, and this one goes off to become your right carotid artery, and this one heads off down here and becomes your right subclavian artery. Over here, your arch, number 4, turns into your aortic arch, and it goes all the way down. That becomes your descending aorta. So this is starting to look something like an arch. And this number 3 over here becomes your left carotid artery. Out of interest, your left subclavian artery, which you'll know is the 3rd branch, gets made as a new artery. That's not in these arteries. What's interesting is this bit, this segmental number 6, this is your PDA. So this half of it is your PDA, which is connecting to your aortic end. The other half of it goes and becomes your left pulmonary artery, and that kind of grows into this bit and becomes your left pulmonary artery. and your main pulmonary artery. So that's kind of where it comes from. Now we've kind of got something that kind of should resemble a little bit like that, something. So that's where it comes from. If you imagine that the body just maybe forgets to generate a few of those vessels, maybe it does it in the wrong order, you can see how a whole host of head and neck problems and you know, your vascular rings and all this stuff can happen. It's very complex, but pretty impressive. So a real quick recap on fetal circulation is something that's familiar to everybody. Okay, cool. So the placental circulation, so mum's down here, and yeah, I mean, you guys know this way better than me, but your lovely oxygenated blood comes all the way up here, goes through your ductus venosus, which degenerates later on, and up to your IVC. It goes up to your right atrium. And because the pressure in your lungs, the baby's lungs or the fetus lungs are so high, they're full of water. So your pulmonary vascular resistance is high. The blood doesn't want to go and doesn't need to go to the lungs. So you know, some of it will go to the left ventricle, right ventricle, and then shoot up through the main pulmonary artery. And it doesn't need to go to the lungs. It will just shoot across your PDA or your arterial duct, and go and join all that other oxygenated blood, which has gone that way, and head off to the body. So that's why you need it in fetal life. But that was obvious. Let's carry on. So two other things we're going to talk about is the normal and abnormal pathophysiology, so what happens normally and what doesn't, and our treatment options. So what happens normally, what's supposed to happen? So normally the duct should close in the first 24 hours of life. You want blood to go to the lungs now, so you want it to close. So what should happen, so your baby is born, baby opens up their lungs, they get a load of oxygen and they increase their PaO2. So that increase in the PaO2 can cause the duct to close. Another thing that happens, so your placenta gets cut off, you don't get any more prostaglandin, which we know keeps ducts open. So that stops coming, and the baby's not receiving that anymore, so the duct will close. The last thing is bradykinin. So when the baby's born, they take a big deep breath in. There's that shear stress, which of when they open up their lungs, and that causes bradykinin to be released, and that again targets the duct and helps it to close. As we all know, that doesn't always happen, so it's less efficient in a premature baby, and for many reasons, and it can cause problems. So we'll go through some clinical signs. I hate lists, but this is one of them. So the first thing you'll hear is that what's called a machinery murmur, and that machinery that comes from back in the early 1930s when they started describing it. Nothing really much has changed, but you get this really loud murmur. It's at the left, high upper left part of the chest. You get a wide pulse pressure. That's because you get this diastolic runoff, which we'll talk about in a minute. So you'll see that on your art traces, your UAC, your art lines. Bounding pulses, so you know this, that as we'll talk about in a second, the heart's trying to work overtime to just kick blood out because it's getting so much runoff down the duct. So you get this, you get left heart kind of overload, so your heart's working overtime, so you get bounding pulses and like a heaving sensation on the chest. Because you get this diastolic runoff and the heart's working overtime, they don't feed very well, and they don't grow very well. And we'll talk about in a minute, you can get lots of fluid on the lungs, you need your increased ventilatory requirements, you just can't get these babies off the ventilator. No cardiac talk would be good without, or complete without, an echo image. So this is your what we call a ductal cut, or ductal view. And if I just, so this down here, this one, this black thing, that's your RPA, your right pulmonary artery. Your LPA is somewhere in here. Your aorta is running down here. It's a bit closer. And that's your duct. That red splurge is your duct, this thing. And red flow, so red towards, that's my probe up here. Red is towards, blue is away, the flow of blood. So that tells me that blood is going that way, which is left to right. So your aorta to your pulmonary artery. And that's your your PDA, and they can measure it in various places to tell you about the size of the PDA, and they usually measure it at the pulmonary end because that's where it usually narrows first, and we saw that in our tricuspid atresia baby that just went over to PICU. So that's where they measure it, but mostly it's all about what the hemodynamics are doing, which way that blood flow is going, what's it doing to the heart. Doesn't really matter how big the duct is. I mean, if it's a 3 millimeter duct, yeah, that's massive, but at the end of the day, it's important to know what it's actually doing to the baby. So whilst we're on that, let's talk about the complications. Over here, another beautiful heart. So when, let's keep an eye on the time. So what do I talk about when I mean it's, you know, disrupting the hemodynamics of the heart? Is a hemodynamically significant duct. Well, as you remember, when babies are born, in the first few days, weeks of life, their pulmonary vascular resistance drops. So your PVR drops. Your systemic vascular resistance goes up. You know, your placenta's been cut off and everything should be high. This is the way it should go. So let's talk about where the blood's going again. I'm always a fan of just thinking about where the blood flows, and you can figure out everything else. So blood goes in through to your RA, down to your RV, up to your lungs. Your PVR is low, right? So you should go to your lungs. Your blood preferentially wants to go to your lungs because it's a lot easier. So it goes to your lungs, then comes back into your LA, down to your LV, up to your aorta. But because it's so easy for blood to go to the lungs, it's got a choice here. So it just a lot of blood preferentially likes to go to the lungs. So the lungs are seeing more blood. So obviously some goes down there. I mean, a lot should go down there. But your lungs are going to see more blood. So this is a much fatter line. Therefore, this is a much fatter line. Therefore, this heart is seeing more blood. That side of the heart is seeing more blood. So it just that one dilates. That side of the heart dilates. So that's you get on echo. You can see a dilated left heart. What also can happen is you get ductal steal. When if a lot of blood wants to go that way, not much is going, or not enough is going down through aorta. So you get reversed diastolic flow or ductal runoff, and that will cause you to have low diastolic pressures and poor gut perfusion and things like that. Sorry, I forgot, when you get a lot of blood going to the lungs, that's when you get like a fluid on the lungs and pulmonary edema, and that can cause problems, and you can't get children off the ventilator, or you might need some diuretics and stuff. So there we go, left heart dilatation, ductal steal. Sometimes, so it's not all bad though, like you know, that is what you're kind of looking for on echo and chest x-ray, pulmonary edema, things to make you think this is a hemodynamically significant duct, but it's not all bad. Sometimes you need your duct, right? So you might, and there's a couple of times when a duct is helpful. So it's not always straightforward, black and white, you've got a duct, let's close it, or you've got a duct on a ventilator, let's close it. There's two very clear reasons why you might not want to close it, and why it's not an easy decision to close it. One is pulmonary hypertension. So if you've got really high pressures in your lungs, your pulmonary vascular resistance just didn't drop for whatever reason, you've got blood coming in here, going down here, going up here, you just can't get, in a pulmonary hypertensive crisis, blood just does not want to go to the lungs. It cannot go to the lungs. So in that case, you've got like a blow-off valve. So you can, blood can go through, not only can blood shoot across your aortic septum if you've got a hole as a blow-off valve, but it can also go through your duct, and you get right to left shunting, and that gives that baby a cardiac output. So that can be helpful in those circumstances. You might think twice about closing that sort of duct. In cyanotic heart disease, for obvious reasons, if you've got, for example, a massive like pulmonary stenosis, or pulmonary atresia, well, I won't complicate it, pulmonary stenosis, you've got blood coming up in here and it just can't, it can't get up there, it just can't, not enough is going that way. So it shoots across your septum, down here, up through here, and you get mixing at the ductal level. So you'd use prostaglandin to keep that open, and that's like a ductal supply. So you might not want to close that one. So all these babies that have a PDA that need closed, and they all need full echoes, to make sure they've not got a reason why we shouldn't be closing it. Okay, cool. So we've talked about what you might see on echo and the complications you can get, but let's do something about the duct now. So hands have gone all sticky. So complications, so up to treatment options, up we go. So there's 3 things you can do about a duct. One, you can treat medically, you can do a surgical intervention, or you can ask the catheter people to come and plug something. So let's talk about first medical interventions. So there's conservative approach. So you can, as we've talked about and why it's helpful, you can do appropriate ventilation. So you might want to increase the PEEP on these kids to try and help that pulmonary edema. You might want to fluid restrict them just to help that pulmonary edema, get some fluid off them. Obviously you're going to fight, they're not going to grow, so that might, you might want to think about closing it. And furosemide just can help the problems that you're having in the lungs. If you decide to close it, you can start with ibuprofen. Some places used to give out paracetamol, and I haven't found anywhere that's doing that recently. We certainly don't. And there's clear clinical guidelines for giving ibuprofen. St Thomas's, we give 3 doses, 24 hours apart. I think it's 10 per kilo, 5 per kilo, 5 per kilo. And if that doesn't work, you can give another course straight after it. See if that helps. But not every baby can get ibuprofen. There are contraindications. Some obvious complications are thrombocytopenia. So if your platelets are low, you can't give it because ibuprofen inhibits the platelet action. If you've got an acute kidney injury, ibuprofen attacks your kidneys, so that's not you're on a hiding to nothing. If you've already got a massive IVH, you're at high risk of bleeding, so you can't have it. And if your bilirubin is over the exchange transfusion line, then that's another contraindication. So not all babies can have this. So what would you do then? Well, you might think about surgery. I really am into my cardiac history, don't ask me why, but what's really interesting about the PDA is the first ever heart operation that was ever done, and it's this guy is a guy called Robert Gross, and this is Sweeney, and she was 7 years old, and it was in Boston, and believe it or not, it was in 1938 when it first ever happened. And she was an intractable heart failure. Left side of the heart was massively dilated. She was dying, and they thought that the PDA was this doctor was helping her, but he thought maybe it wasn't helping her. Maybe we should try and close it. And he closed it, and she lived to a good age, and she survived the operation. It was phenomenal. It was the first ever heart operation that was successful. So that's the background of PDA. These days we ask our friendly surgeons to come and help us out. You probably see this guy more on the unit. This is Simone Spedurin, this is Jana, and this is Mr. Austin, and there are cardiac surgeons at the Evelina, and they do duct ligations on the unit now, I think, but not everything's straightforward. It's not just a matter of going in and clipping that duct or ligating that duct. It's not that easy. And Simone will tell you, he's told me before, like when you've got a duct, when someone goes in, they go do a left lateral thoracotomy. It's like cutting through butter sometimes, and so it's not easy. And all these vessels are pink, right? They all look the same. I mean, I'm not a surgeon, but they all look the same. So there are complications. A couple of complications. One, you can cut off the aorta. They can clip the wrong thing, and that has happened before. And actually, that's how they found out they could do coarctation repairs, because someone, when they did a PDA ligation back in the day, they accidentally clipped the aorta, and it didn't kill the patient's leg. So, but anyway, that's a complication. They can also, this is very close to the LPA. They can also clip the LPA. When they come back to echo. These are things they're looking for after the operation, why they must have an echo before they leave the hospital again, because to make sure there is flow in the abdominal or in the aorta, that there is flow in the left pulmonary artery. Another thing they can do, so the recurrent laryngeal nerve goes under, the left recurrent laryngeal nerve goes underneath the PDA or the ligament that's left and heads up, so they can ligate that, and it can cause a palsy of the left vocal cord. So there are complications. I mean, if the clip can fall off, they can put it on and it can fall off and be a complete failure. And it can bleed a lot because, like I said, it's like cutting through butter. So that it's not straightforward. So not all babies will have a ligase. Some babies might be lucky enough and big enough to have an intervention. So you call someone like Matt Jones to plug it. So the youngest I think he's ever done is, I think, 800 grams. But it's a size thing, and these are called the Amplatzer devices. And they come in all shapes and sizes. Ducts are not straightforward. All ducts, no duct, one duct's the same as the other. Some are tortuous, some are long, some are short and fat, some are all sorts of different shapes and sizes. So they have devices that are all different shapes and sizes too. And the weight limit is limited by the size of the equipment. So I'm sure they'll do smaller and smaller as time goes on. And this X-ray is what it looks like. So you can tell if someone's had a PDA ligation or a PDA clip, or if it's a surgeon, they'll put a clip there. If it's a device, it looks a bit like that. Or some sort of black and white version of one of these things. That's it. So just to come out, so we've talked about a normal heart, what it looks like, what a PDA is, how it was formed, which I find really interesting, when things go right and when things go wrong, and what we can do about it if we need to.